Hi, I'm here with Dr. John Mandrola from Louisville, Kentucky, USA. Thank you for being here with us at the SOBRAC meeting. We're going to be talking about stroke prevention and atrial fibrillation. So, first question I'm going to make to you, is anticoagulation the necessary treatment for every single patient with AFib?
Well, first of all, thanks for having me. It's really a pleasure to be here. No, it's not. And I think this dates back to the early trials. Even in the early trials, the authors would say that the risk of stroke and atrial fibrillation varies so much per patient. I mean, you could just think about the CHA2DS2-VASc score. So I would say the answer to that question is no, and I think the big challenge is deciding which patients and how much risk does the benefit of stroke prevention and bleeding balance out.
The reason why I ask you that question is because it's the same disease, right? If for a CHA2DS2-VASc 0 or 9, it's the same disease, AFib, so it's not only about the mechanical contraction. There's got to be something else.
I'm so glad you asked me that, because I think the disease or condition of atrial fibrillation is changing, right? We now, in the old days, you had to have symptoms, then you had to go to the doctor, then you had to have an EKG, and you had to be in atrial fibrillation for a long time. But now, with smartwatches and with these monitors, I really think that Søren Didriksen from Denmark is right, that AFib is changing. And what it was and what it is are two different things. And so I don't think it's the same. I think it's a different condition in different people. And this is the big challenge for EP going forward.
So, and let's say, do you believe in alternatives to anticoagulation? Let's say specifically ablation and appendage occlusion. Do they have a role in preventing a stroke as well?
So we have many trials of anticoagulation. As I showed today in the lecture, the evidence base for anticoagulation and atrial fibrillation is so sound, but we have so much less data for appendage closure. And this is one of my criticisms of appendage closure, is that we've done hundreds of thousands of these procedures and we don't have randomized controlled data. We could have it if we did the trials, but we don't have it. So the answer to that question is, I don't know. I want to think it's yes, but I don't know. The seminal trials, as you know, were done versus warfarin, but now the competitor is DOAC. So we don't know. And many of the patients we do appendage closure now are excluded from the seminal trials. So the answer is a big fat I don't know. Now, if they go to surgery and they have atrial fibrillation, we know from Laos that surgical appendage closure works. And as far as AFib ablation, as a stroke reducer, I do AFib ablation, I think it's great, but when you look at the trials of AFib ablation, the rates of stroke are very low. So it's hard to know whether there's a reduction in AFib.
From your clinical judgment, if you have a patient who had an ablation and is, for the best you can tell, is in sinus rhythm and needs to come off anticoagulation for a clinical reason, for a bleeding, for a surgical procedure, something like that, and you know that this patient has a low burden, would you be more comfortable in withholding the anticoagulation clinically?
Absolutely, yes. I do believe this, and I think that post-ablation, we can't really go by symptoms, right? Because we know that ablation changes the symptoms. And someone who was previously symptomatic with AFib, they can be rendered asymptomatic and still be having AFib and still have the stroke risk. But we do now have Apple Watches and we have notifications, and if a patient says to me after the ablation that they don't have AFib, and their watch says they don't have AFib, and they have to come off anticoagulation for a period of time, my judgment, it's not evidence-based, but my judgment is that it's lower risk.
And just to bring another point of discussion, in that case, based on your answer, would you be in favor of offering patients, asymptomatic AFib patients, ablation because of the fact that you can actually decrease the burden, and if they need to come off anticoagulation, we're in a better shape?
I would say...
Or that's a stretch?
I think that's a stretch, honestly. I do a lot of ablation, and I believe in it, but I almost always do it to reduce symptoms, not to reduce stroke risk. And we'll study it more, we'll find out. era of monitoring will tell us the relationship of AF burden with stroke risk, but for now, it's for AF ablation is for symptoms.
Thank you very much. I think, John, you're already an honorary member of SOBRAC. You know, the amount of time that you spend with us, the amount of talks that you're giving during the meeting. Thank you very much for coming. We're very happy to have you.
Thank you for having me.
Thank you.